Hello friends, I'm your mentor Dr. Asma Desai, and today I'm summarizing the topic of extracorporeal membrane oxygenation in the pregnant and the postpartum women. This topic has been taken from the TOG article which is released by the Royal College of Obstetricians and the Gynecologists in 2023. Friends, according to this TOG article, extracorporeal membrane oxygenation is an advanced life support technique used for the selected patients with severe cardiac or respiratory compromise when the conventional approaches are insufficient to prevent significant hypoxia, cardiovascular collapse, or the death. Now, the extracorporeal membrane oxygenation circuit has been shown over here. And the basic principle is to drain the deoxygenated blood from the body, remove carbon dioxide, and replace oxygen and return oxygenated blood to either the venous or the arterial system. Its key components are cannulas, tubings, pump, oxygenator, and the heat exchanger. It can be veno-venous and it can be veno-arterial. Its indication has been shown in box 1 and the box 2. Please have a look. In the box 1, indications for the respiratory extracorporeal membrane oxygenation support. These are given. In the box 2, indications for the cardiac extracorporeal membrane oxygenation support has been given. Please have a look. Its indications and contraindications have been mentioned. An overview of the pathologies that may necessitate the extracorporeal membrane oxygenation support has been highlighted. It should be considered in the patient with estimated mortality in excess of 50% and indicated when the estimated mortality is in excess of 80%. Now, the conditions which are specific to the pregnancy and the postpartum are mentioned in this TOG article. Pregnancy-specific pathology rarely cause severe cardiac or respiratory compromise necessitating this support. Adult respiratory distress syndrome has been found to be the most common indication for the respiratory extracorporeal membrane oxygenation support and can be used by the pregnancy-specific complications such as severe preeclampsia, amniotic fluid embolism, severe peripheral sepsis, and massive obstetric hemorrhage. Pulmonary embolism is the most common in pregnant and the postpartum women and is the leading indication for the cardiac extracorporeal membrane oxygenation support. Pre-existing cardiac disease may be worsened by the pregnancy, increasing the risk of the cardiac failure, pulmonary edema. Cardiac failure may also cause related to the pregnancy such as peripartum cardiomyopathy or related to the ischemic heart disease, which has increasing incidence in the pregnant population due to higher rate of obesity and increasing maternal age. Local data highlighted that obesity was the significant risk factor for requiring extracorporeal membrane oxygenation support during the COVID-19 pandemic. Now, what are the complications of this particular support? Complications are numerous and can be broadly split into the issues surrounding the implantation of the extracorporeal membrane oxygenation, that is cannulation, transport, medical complications such as bleeding, DIC, heparin-induced thrombocytopenia, and complications due to equipments such as oxygenator failure, pump failure, tubing rupture. The most frequently encountered complication is that of bleeding, owing to both necessity of the systemic anticoagulation and extracorporeal membrane oxygenation-induced coagulopathy. Intracranial hemorrhage is one of the most feared complications with significant attributable mortality. Now, how this extracorporeal membrane oxygenation in pregnancy and postpartum works. Multidisciplinary team is required for the management plan. Multidisciplinary team management for the women who require extracorporeal membrane oxygenation support during the pregnancy or the puerperium is highly complex, requiring the team discussion between obstetrician, cardiac, obstetric anesthetist, intensive care, and the team neonatologist and the midwife. Friends, according to this TOG article, considerations for fetal monitoring. In case of the severe cardiac or respiratory failure, fetal monitoring is likely to be abnormal, but emergency delivery may worsen the woman's prognosis. A single auscultation is therefore required at the initial presentation to confirm the presence of fetal heartbeat. If the woman can be stabilized and cannulated onto the extracorporeal membrane oxygenation support, fetal monitoring should be a part of MDT discussion. Regular intermittent auscultation is helpful at the gestation below viability, as confirmation of intrauterine fetal demise necessitate the discussion on the emptying the uterus. At gestation above the age of viability, MDT decisions about monitoring with the CTG or the ultrasound are dependent on whether the delivery would be undertaken with abnormal results and whether the delivery of the fetus is feasible and in the best interest of the women. In most cases, the delivery is undertaken to aid the maternal condition, therefore, fetal monitoring is normally limited to confirming the presence of fetal heart only. Now, what are the considerations for delivery of the fetus? The main reason for delivery are to improve the maternal condition. This may be through enabling the prone positioning after the delivery, which has shown to improve the oxygenation and reduce the mortality. Once established on extracorporeal membrane oxygenation support, prone positioning and advanced ventilation strategies are less impactful, as extracorporeal membrane oxygenation will support the gas exchange functioning of the lung, but may still be considered when the delivery is felt likely to improve the maternal condition. When delivery is not felt to benefit, the maintenance of the left lateral tilting to reduce the arteriocaval compression by the gravid uterus will aid the venous return and uterine perfusion, and thus should be maintained during extracorporeal membrane oxygenation cannulation, transport, and ongoing support. Friends, according to this TOG article, what are the specific risks of extracorporeal membrane oxygenation in the antenatal patients? Bleeding is actually the known complication and same risk as present for the pregnant women. There are the risks specific to the pregnancy, such as preeclampsia, preterm pre-labor rupture of the membranes, subsequent chorioamnionitis, preterm labor, potential for more challenging control of any pre-existing medical conditions such as diabetes, and the postnatal management of the women receiving extracorporeal membrane oxygenation support. Actually, immediately postnatal women or those who delivered their baby while on extracorporeal membrane oxygenation have the risk of postpartum hemorrhage, including the retained product of conception. Therefore, MDT discussion should include the approaches to manage the bleeding and infection risk, both pharmacologically and surgically. Now, the care of the patient surviving extracorporeal membrane oxygenation support. Overall survival rate after receiving the support are high, with a recent report suggesting more than 75%. Ongoing antenatal care undoubtedly follows a high-risk pathway, utilizing the MDT working as required with specific management tailored to the underlying pathology and the treatment requirements. The prolonged periods of the hypoxemia may predispose the fetus to the risk of growth restriction, antenatal hypoxia, brain injury, and therefore regular ultrasound scans will be required. Psychological sequences of the critical illness may be just as disabling as the physical adverse effects. Now, the neonatal management and prognosis. Fetal survival in extracorporeal membrane oxygenation supported pregnant women is reported 65 to 70%, although outcome will vary based on the indications for extracorporeal membrane oxygenation, gestational age at cannulation and delivery, and the other fetal complications. Friends, to conclude this TOG article, this support system is a safe and effective treatment for the severe cardiac or the respiratory failure in the pregnant and recently pregnant women and the people. The mortality rate decreasing over the time with approximately 75% of the patients and 65 to 100% of the neonates survive. It is a complex and require multidisciplinary team discussion. Delivery is typically undertaken for the maternal reasons, and monitoring of the fetus is normally limited to the fetal heart rate auscultation. This is all about this TOG article, friends. Please have a look on this box 1 and box 2. Happy studying. Have a good day.